Good morning, everybody. It's a pleasure to be here with you this morning. I'm going to be talking about the clinical course, briefly reviewing the clinical course of these three conditions, and then the symptoms that crop up. Some of them are unique to some of these conditions, but some of them are shared by all of them. So I'm going to be discussing, having a slide on each particular symptom. So we'll get going. All right. So as Dr. Bauer just alluded to, very early on in the disease course, these three conditions share a lot of overlapping features, so they can be very difficult to distinguish from each other, and they can look alike. And they can also look like other conditions. So typically they can be mistaken for Parkinson's disease early on, like he alluded to, or other dementias, or other types of cerebellar ataxia, which there are many different causes, and that's for MSAC. And so this can either lead to patients being misdiagnosed early on, or this period of uncertainty of diagnosis, which can be sometimes anxiety-provoking for patients. But sometimes if there's these very early hallmark signs that are specific to these conditions, it can be helpful for the physician to try and pin down the diagnosis earlier on. And I've given some examples there. And tests can also be helpful, but tests in and of themselves are not diagnostic. They're just helpful to try and rule things in or rule things out. The progression of these conditions is variable. They tend overall to progress faster than Parkinson's disease. And no two patients are exactly alike. So you can take a number of patients with PSP and look at how they progress over time, and every patient will be unique. So they will not be exactly alike in terms of what symptoms develop next, or which symptoms are the most bothersome symptoms. So it's different for each patient. And overall, as the diseases progress, they mostly tend to affect quality of life, and patients tend to need more and more reliance on other people, so they become more dependent. And the survival time is very variable in these conditions. So as Dr. Bauer had previously alluded to, PSP can come with different presentations. So there's different clinical flavors, if you like, of how PSP affects the brain. But in general, it progresses with significant troubles with balance and falling. Vision problems can be very prominent, and there's a whole host of these that I'll go into later. Speech ability is reduced and less, and it can become hard to understand patients when they're trying to articulate. And usually by around the 3 to 4 year mark, the patients are becoming more dependent in their self-cares. The median survival is 6 to 9 years, but that's median. So that's what's the most common survival time if you take a large range of patients and look at all the survival times. But that can be shorter than 6 to 9 years, or it could be longer than 6 to 9 years. For CBD, again, there's these different clinical presentations early on, but in general, it tends to classically start off in an arm or a leg with very significant stiffness, rigidity, abnormal posturing of that limb, and then spread to other limbs. The gait walking can be affected, balance can be affected. There can be speech difficulty, problems with eye movements, and cognitive decline, and then alien limb may develop in patients. And the median survival is about 5 to 8 years. And then in multiple system atrophy, there's the two different types that were described. And the disease progression in MSA is, again, very variable. So it's been reported that it can progress somewhere between 1 to 18 years. And on average, patients experience significant trouble with blood pressure control and bladder early on, around 2.5 years into the disease course. They usually need a walking aid by about 3 years, a wheelchair between 3.5 to 5 years, and become bedridden between 5 to 8 years. And again, these are averages. And their survival is on average between 6 to 8 years, but it can be much longer than 15 years. So Parkinsonism is common in all of these conditions, as Dr. Bauer has gone over. Often it occurs early on. In multiple system atrophy type C, which is the cerebellar ataxia type of MSA, patients may not have any Parkinsonism at all, but they may develop a little bit of that later on in the disease course. Parkinsonism means that they'll have at least one of these symptoms: stiffness of the limbs, slowness of movement, tremor, or loss of balance. And the best medication to treat this, at least all patients are recommended to try levodopa to try and treat stiffness, slowness, or tremor. So that's the most effective medication that's been shown. And about 1 in 3 patients will get a modest response to the medication. And that tends to be early on in the disease course. Over time, people who may have responded to this medicine will lose that benefit, but it's worth trying early on if Parkinsonism is there. The other Parkinson's disease medicines don't tend to work as well. So they're things like pramipexole or ropinirole, Azlect, and so on. They don't tend to be very effective. And then physical therapy is recommended for rigidity. For posture instability, so loss of balance and falling is very common across all 3 conditions. It can occur early on or late in the course. And often patients are aware of this. They feel off balance or report falling, and physicians will test for this in the clinic by doing a pull test, having you stand and then pull you back sharply and to see can you maintain your postural reflexes and keep your balance. We take falls very seriously because they put patients at risk of injury. So falling, hitting their head, falling and breaking a bone. So if this is picked up, it's very important patients see physical therapy to do balance training, balance exercises, learn how to prevent falls, or if they fall, to minimize their impact on fallings. And if patients have osteoporosis or osteopenia, which is bone thinning, you're at higher risk of having a fracture when you fall. So we recommend calcium and vitamin D supplements. So I also should mention other things are important there too. So it may be that patients will be much more stable using a cane or a walker or wheelchair if they're imbalanced, and having the right footwear can be helpful as well. And these are all features that will be reviewed by physical therapy in their talks later today. Freezing of gait can occur. It's typically reported in PSP. It's uncommon in CBD or MSA, but it's been reported in those cases as well. And it can occur anytime. It tends to occur early if it's going to happen in PSP. And patients will say, I feel my feet stick to the floor. And typically this happens when you stand up and try and start walking and the feet are stuck. And it might be one foot is stuck or both feet are stuck and they really can't get going. It's like the feet are glued to the floor. And then after several attempts, or maybe a period of time lasting seconds, it might be minutes, then the feet will be able to start walking. And then it also tends to be brought out again if people walk through a doorway or they're turning. So the feet tend to stick. And this is a real problem because people can fall when the feet stick. They lose their balance and fall. So there's a number of medications that have been shown, but it's a little hit or miss in terms of whether they will help freezing of gait, but it's something that could be discussed with your physician as to whether or not it's worth trying them. Levodopa's fairly straightforward medicine to try. The other ones listed there may have some side effects that may not be suitable for trying. So it's on an individual basis as to whether they should be tried. Physical therapy and occupational therapy can be very helpful for gait freezing, and there are some tools and techniques that can be helpful. So for example, using a walker with a laser that shines a laser beam on the floor gives a visual cue for stepping. So it's like a visual cue to step over the laser marker, and that can help overcome gait freezing. And similarly, some walkers are fitted with metronomes, and say they will tap out a beat, and you walk in time with the beat, and that can help gait freezing as well. And there are other types of techniques reported that can be helpful. And when it comes to turns, doing a turn in a large arc, so turning like a bus, so the bus will turn and make a big circle rather than trying to turn on the spot. That can sometimes prevent gait freezing when doing turns. So they're things worth trying. Myoclonus can happen in any of the conditions at any time during the disease course, and this is a shaking of the limbs. Typically, when the arms are held out in the air or doing something with one arm or both arms, they might shake or jerk. It can sometimes look like a tremor, but the difference is it's very brief, it's irregular, and it looks like lightning-like. It's a very brief jerk. Most of the time, this is often not bothersome at all. So it's a little bit of a shake, but it really doesn't interfere with any activities when you're using your arms. But if it is bothersome, the two medicines recommended to try are either clonazepam or levetiracetam. Okay. Tremor, again, can happen in all of these conditions at any stage, and it can happen in an arm typically. It can also happen in the leg, and it's a rhythmic movement. It's a irregular movement, a rhythmic movement of the limb. It can happen when the arm is resting or when the arm is held up in the air and doing actions with the arm. And medications could be tried, but overall it's modest in terms of the benefit they give. But the best medications to try are levodopa, or the medicines used for essential tremor can be tried as well, and they're listed there. If medicine is not helping dampen down the tremor and the tremor is bothersome, seeing occupational therapy can be helpful because they can look at using weighted utensils or other instruments that help. Holding a heavy object can sometimes help manage the tremor better, for example, weighted spoons and that kind of thing when eating. And there are some anti-tremor devices that can be bought. There's a lift device, which is like a spoon that has a counter movement. So when if the hand is shaking as you're bringing a spoon up to the mouth, the spoon will move in a direction opposite to the tremor. So the idea is it overall reduces the amount of tremor so you can feed yourself without spilling things. So there are some objects out there. Dystonia refers to very stiff and rigid postures, and it typically affects the arm or the leg in CBD, and it can affect the neck in MSA or PSP. And in those conditions, it tends to be what we call anticollis, where the head wants to pull down or pull forward. And dystonia in these conditions can again occur at any stage, early on or later in the course. And overall, if it's mild and not bothering or causing any interference, we tend not to treat it. If it's bothersome, for an arm or leg dystonia, particularly if the arm is held or fixed in a posture and it's very painful, physical therapy to do stretching of the limb is important to stretch out that limb and help relax the muscles. Botox into the muscles can be helpful to relax them as well. And splinting of the arm or the leg can be helpful to try and correct the position. Some patients have a dystonia where the hands really clasp down and it's hard to open the hand, so there can be hygiene problems with the hand, or it's just very painful because the fingernails are digging into the fist. So occupational therapy can make splints to put the hand in a more neutral position and make it more comfortable for patients. So basically, occupational therapy is your friend for dystonia to try and help out. Some medications can be used as well. So these are dystonia medicines listed below. But again, it's kind of a variable response how much benefit they will give. So they can be certainly tried, but if they're not helpful, then we just recommend stopping the medicines. We don't like to continue medicines that aren't helpful because they have side effects and want to avoid those. In terms of neck dystonia, depending on the position the head or neck is getting pulled into or has stiffness, we can do Botox injections to help relieve some of that neck stiffness and pulling. Okay. Spasticity is a symptom or a sign rather that's typically seen in MSA and CBD. less so in PSP, and again, it can happen at any stage. But usually this is not something patients recognize. It's something that's picked up by the physician. So when you're having your reflexes checked, the reflexes can be very jumpy. So the knees can kick out when they're getting tapped with the reflex hammer. And sometimes there's other signs of spasticity as well. If this is not causing any problems to patients, then we don't treat it. But if it's symptomatic, if it's bothersome, bothersome spasticity tends to cause symptoms of cramping in the arms or legs or stiffness. And if that is bothersome, then there are antispasmodic medications that can be given to relax the muscles. And I've listed there baclofen, that's the most common one that we use. Physical therapy to stretch out the muscles is very helpful. And botulinum toxin injections can be used into muscles. So for example, if there's a lot of leg spasticity, the leg muscles can be injected with Botox to help relax them. Cerebellar ataxia is typically only seen in MSAC, but there have been some case reports of patients with PSP presenting with ataxia. This, if it happens early on, and ataxia is clumsiness. And essentially, if people have cerebellar ataxia, they look like they're drunk. Their speech is slurred, their arms are clumsy, legs are clumsy, walk with a wide-based gait. So when they're walking, the feet are apart, staggering, veering, and the speech is slurred, like you're drunk. And this can be very mild, or it might be bothersome. If it's mild and overall not causing any limitations in terms of speech or use of the arm or walking, then we don't tend to do any specific treatment. If it's bothersome or severe, then the therapists, again, are very helpful. So speech therapy can help treat the slurred speech, and slowing down the speech to speak more slowly can be helpful. Occupational therapy and physical therapy can look at strategies to help with troubles that limb clumsiness might be affecting. So people have clumsy arms, they may have trouble with riding or eating and that kind of thing, and occupational therapy can help. And then gait aids are helpful, again, if there's a lot of imbalance, so cane or a walker or wheelchair. Unfortunately, there's no specific medicines that we can prescribe that specifically for cerebellar ataxia. There are no medicines to improve cerebellar function. So the mainstay of treatment is therapy. Orthostatic hypotension refers to lightheadedness on standing up, and syncope refers to fainting. And this is very typical in MSA. So the problem is it's very bothersome for patients, and it's also unsafe if you do stand up and faint. So again, this is a symptom that's taken very seriously, but the good news is there are many treatments available to try and control the symptom and improve it, so it can be managed. So the very first thing is lifestyle changes, so drinking plenty of fluids, making sure you're not dehydrated. And we usually say, as a rule of thumb, drinking 6 to 8 glasses of water per day, and adding salt to food, or at least not avoiding salt. That will help bulk up the blood volume. Whereas if people are trying to avoid fluids, particularly patients will often say, I don't like to drink very much because I have bladder problems. I don't like to go to the bathroom so often. So they tend to become more dehydrated, and they're more prone to getting orthostatic hypotension. So fluids are very important, adding salt to food, and then using compression garments. And these are specifically recommended are thigh-high stockings, so stockings that go from the feet all the way up to the thigh, or that go up to the waist, or abdominal binders, which are binders that go around the waist. And the idea there is that it will squeeze the big veins in the lower body and help push that blood up to the heart and prevent the blood pooling in the legs when people stand up, so less likely to feel faint or lightheaded. And those two things are very simple, fluid, salt, and the compression garments, but they tend to be very effective. So we recommend those, and also we're not adding any medicine. It's just lifestyle changes. There's a number of other things listed here that can be helpful. So eating small meals, maybe 5 small meals per day as opposed to 3 large meals. If you eat a large meal, blood gets diverted to the gut, and it makes people more likely to feel faint when they stand up. So eating small meals. Caffeine or a salty drink will push up the blood pressure by about 10 points for about an hour. Sometimes people find this helpful in the morning if they drink a strong coffee or drink a V8 juice. It'll push their blood pressure up enough. So some people will have that drink by their bedside and drink it in the morning, or drink a glass of water in the morning before they get out of bed, and it can be helpful. For patients where these things are helpful but they're not sufficient, they're still feeling lightheaded or still feeling faint, then medications can be added in. And I've listed in the ones that we typically use. Midodrine is a medicine that's given 5 times a day. The last dose should be at 5 p.m. or at least 4 hours before going to bed, because we do not want the blood pressure to be, if patients lie down, the blood pressure can be elevated, and we don't want very high blood pressure lying down. So we want this medicine effect to have worn off by bedtime. Same with fludrocortisone. That's given typically once a day, first thing in the morning. It can be given twice a day, but the second dose has to be no later than noon. For the same reason, we want the effect of the higher blood pressure to have worn off by bedtime. Pyridostigmine can help, may also modestly help low blood pressure without causing this overshoot of blood pressure. And then droxidopa is a new drug FDA approved in the last few years, and the dosing is given there. Droxidopa, though, in our experience, tends to be limited by expense. So the other 3 drugs are much cheaper. In terms of bladder and bowel control, it's very common in MSA, often early on, but can happen in the other conditions as well. And one main problem people complain of is there's frequency, needing to go to the toilet all the time, and urgency, or incontinence. So if it's mild, we don't tend to treat it. If it's bothersome, for example, getting up every hour overnight to go to the bathroom, or loss of control of the bladder, then medications can be considered. The first 2 medicines that are listed there are helpful, but we actually tend to avoid those because of side effects. They tend to cross into the brain and can cause problems with confusion, particularly in people over age 60. They can cause dry mouth, problems actually emptying the bladder fully, or constipation. But the third drug listed there, mirabegron or Myrbetrek, is a newer drug. It's less likely to cross into the brain, so less likely to cause side effects. So that's a better option. And then for some patients report that they feel their bladder doesn't empty fully. So they're on the toilet, they're trying to urinate, but they still feel they have some urine in there, or they may have recurrent urinary tract infections because they're not emptying their bladder fully. And that problem needs to be seen by a urologist to confirm if there's urine retained in the bladder, because that needs to be treated with catheterization. So getting taught how to catheterize yourself to make sure the bladder empties fully, so you're not getting predisposed to infections. Okay. Vision and eye problems tend to be in the domain of PSP. They can also happen in CBD as well. And as I mentioned earlier, there's a whole host of problems that can happen. Double vision can be problematic, and that can be treated with prisms prescribed by ophthalmologist. Patients with PSP often complain, my eyes are red, they're itchy, they're watery, they're dry, I'm very sensitive to light, and I have to wear dark sunglasses. So in that situation, if there is light sensitivity, dark glasses can help reduce some of that irritation. For eyes that are dry, using artificial tears are helpful, or there is a treatment called autologous serum tears, where a patient has a blood sample withdrawn, the serum part of the blood is taken off and spun down, and that is actually formed into tears that can be dropped into the eye, and apparently that's very helpful. And that's done through ophthalmology departments. Some patients have trouble looking down or looking up. This poses a real problem going up and down stairs if you can't look down or look up. Or it also poses a real problem sitting at the dinner table and trying to eat your meal when you can't look down at your plate. You can't see down. So a way of overcoming this is using mirror prisms, and they're prescribed by ophthalmologists. Some people have a problem where their eyes blink all the time, or they actually blink shut and spasm shut and they can't open them. It's called blepharospasm. Or some people have a problem where their eyes just close and they really can't open them. It's not that they're blinking or spasming, they just can't open them. And that's called apraxia of eyelid opening. And both of those problems can be treated with botulinum toxin injections around the eyes and the eyelids, and that will correct the problem. And the injections are given every 3 months. For more bothersome blepharospasm or apraxia of eyelid opening, using eyelid crutches can help. So this is prescribed by ophthalmology. It will be a crutch to try and prop the eyelid open so it doesn't close. Drooling is common and tends to happen later on in MSA or PSP, and the treatment for this is botulinum toxin injections into the parotid gland. So the parotid glands are the largest glands that make saliva in the face, and you tend to use a type of botulinum toxin called Mayo block, which has a side effect of causing mouth dryness, which is helpful. And the parotid gland is injected in 2 spots on each side, and it lasts for about 3 months. So for bothersome drooling, that's recommended, and it doesn't have side effects of taking a medication. If a medication is used, we tend to recommend nortriptyline or amitriptyline. These is antidepressant medicine, but it can be helpful in patients because it causes a side effect of dry mouth, so it helps drooling. But it can also be helpful if people have trouble falling asleep at night, because it's given at nighttime and helps people sleep, or if there's depression and they need treatment for depression. So you can kill 2 birds with 1 stone, or 3 birds with 1 stone if you're using a medication for that reason. Okay, stridor can occur in MSA, and it can occur at any time. Usually tends to occur later rather than early on. But this is a problem where the vocal cords want to close involuntarily. So typically our vocal cords will be open, allowing air to pass from our mouth and throat down into the lungs. But in MSA, sometimes the vocal cords will close or spasm shut involuntarily, so it's hard to get air through. And if you're trying to pass air through a narrow passageway, that causes a noise. And this can be picked up or typically heard by patients' spouses at nighttime when they're sleeping, that they're making a very harsh breathing noise when they're sleeping. And it can sometimes happen during the daytime as well. If you suspect this, it's important that you see sleep medicine to have an evaluation. Typically they will look for this by doing a sleep study and looking for stridor overnight when people are sleeping. And if it's picked up, then there's a treatment for it called CPAP, which is the same treatment as used in sleep apnea. And the idea of that is it will use increased air pressure to try and keep that airway open when people are sleeping. Sometimes this can be severe or life-threatening, and in that situation, patients are referred to ENT and considered for tracheostomy. Okay. The speech and language and swallowing disorders are all listed here. I'm not going to go into them because there's this dedicated lecture on this after lunch with Dr. Clark. So we'll pass over those. Cognitive impairment and dementia usually happen in PSP or CBD. Tends to be uncommon in MSA, although it can occur. But in MSA, people tend not to develop troubles with cognition or dementia. In PSP or CBD, it can occur anytime, again, during the disease course. Usually memory is fine, memory is not the issue, but there's different patterns of how these diseases can affect cognition. So one pattern is called frontal subcortical pattern. That's where people have trouble with executive function, they have trouble with attention, concentration, keeping on task. It's slow thinking is slowed down, it's hard to get information out, but the information is in there and they can access it, but it's hard to kind of get the information out. So everything's overall slowed down, and people may have poor organization skills. In a different type of cognitive impairment, what we call parietal type, people have trouble with calculation or 3D shapes or construction, kind of visuospatial difficulties. And there's other types. These are just some examples. If it's recognized, it's important just to educate people. Look, there's some cognitive impairment developing, or if it's severe enough that it's interfering with day-to-day activities, such as no longer being able to look after medications or needing assistance with finances or needing assistance with other activities, that would be moving into the realm of dementia. So it's important just to identify this and see where do people need help. Medications can be trialed, but they tend to be most effective if there's a memory component, so like Alzheimer's disease. If they're used for these other cognitive problems, they tend not to be as effective. But that's something that's usually discussed on an individual basis with your physician. Okay, alien limb is a problem that's really specific to corticobasal syndrome, and it happens maybe in about 50% of those patients. And it can occur anytime. Patients say, my arm or my leg is not mine. It has a mind of its own, it wants to do its own thing, I can't control it. And so for example, the right arm might be affected. The right arm wants to reach out and grab things, wants to elevate up in the air, and it wants to do its own thing. It's kind of out of control. And patients might use the other hand to try and restrain that arm, or put the hand in the pocket to try and restrain it, or sit on the hand, so it's not doing its own thing. So this is a difficult symptom to treat. Usually occupational therapy might be helpful. Sometimes there's ways of trying to restrict the limb so it's not doing its own thing. But the main thing is education. And if we see that, it's usually a marker that this is a corticobasal syndrome. Okay. Apraxia is a problem where the arm, typically the arm, but it can affect the leg as well. The strength is normal, the sensation is normal, but people cannot use the arm or leg. It's just not working like it used to. And examples people might give, like, I can't throw a ball, I can't pet my dog, I can't brush my teeth. So it's doing a specific task with the hand. Typically, it's using trying to use the hand in a complex configuration, and there's real trouble manipulating that hand or leg. So people, sorry. So for examples here, I've listed here, and in the doctor's office, you may be asked to mime brushing your hair, brushing your teeth, or copying hand signals, like trying to copy different signals. Can you do this, yes or no? So there are signs of apraxia. Unfortunately, there's no medicines to treat apraxia, but occupational therapy can be helpful. Okay. And then sleep problems. REM sleep disorder is in MSA. Dr. Bauer had also mentioned this in his talk. It's typical in MSA. Very rarely has it been reported in PSP or CBD. The treatment for this, the good news is it can be treated. Because the one concern when people are dreaming and kicking out and punching out in their sleep is that they can injure themselves or they can injure their bed partner. They can fall out of bed. So it's important that if this is a symptom, that it's treated. The first line treatment is melatonin, starting around 3 milligrams at bedtime, and the dose can be increased up to 12 to 15 milligrams at bedtime. It's an over-the-counter medicine and tends not to have any side effects, so usually pretty good medicine to use. And the idea is that it stops people kicking out, punching out during their sleep, so that should go away. If it doesn't, despite getting up to a good dose of melatonin, then clonazepam can be used, usually at a low dose. Clonazepam is second line because it's a prescription drug, and also it can cause some unsteadiness, or particularly overnight when people get up to the bathroom. So melatonin is a better choice for that reason. And then bedroom safety is very important as well. So if people are prone to falling out of bed, making sure that there's padding around the bed and that kind of thing. Daytime sleepiness can be a very common problem in all conditions, and sometimes people have their wake and sleep cycle reversed, so they tend to be more active overnight and more sleepy during the day. There's lots of different reasons for troubles with sleeping. It might be because overnight their sleep is inadequate. Either they have sleep apnea or other sleep parasomnias, like periodic limb movements of sleep that are interfering with them getting good restful sleep, or getting up at night very often to go to the bathroom, and then in the daytime they're tired and will need to nap more, or unrecognized or undertreated sleep apnea. So typically if daytime sleepiness is a real problem, or trouble sleeping overnight is a real problem, seeing a sleep medicine doctor can be very helpful to address any issues. Okay. And then behavioral change can happen in PSP or CBD, much less so in MSA. And there's a whole host of changes in behavior or personality that have been described. I've put depression in here because depression is very common and it's treatable. So it's something to consider. But also described in terms of behavioral change are things like compulsive behaviors or agitation, irritability, kind of a change in what the person used to be like before getting in this condition. So they're more short-tempered than before, more likely to fly off the handle and that kind of thing. Or more apathetic or more withdrawn. They don't want to be, maybe they were previously very social and outgoing, and now they've become more withdrawn into themselves and not interested in seeing people. So they're just important to recognize that this is well known. It can happen in these conditions. And so in terms of treatment, it's just counseling and explaining this is part of the disease course. We don't have medicines per se to treat unless depression is a part of this, and we can treat depression. And then I wanted to also talk about caregiver strain, because this is common to everybody who's looking after patients with any of the disorders we're talking about, and can happen the whole time through the disease course. And this is feelings of being overburdened. So if you're the caregiver for patients, you're there on call 24/7. So if patients are up at night going to the bathroom, you're usually up with them as well, and not getting sleep, and then up all the next day looking after patients. And so caregivers can be sleep deprived, they're overburdened, they don't have any personal time for themselves, so no time sometimes to even look after their own health, and neglect their own health issues. And this leads to lots of emotions, stress, guilt, depression, anxiety, burnout. And this is common and known, but it's important to talk about, because sometimes in the office with the doctor, we spend a lot of time focusing on the patient and maybe not as much time focusing on the caregiver, who's extremely important in this whole disease course and journey. So it's okay to feel this way. It's normal to feel this way, feeling overburdened. That's a normal reaction to everything that's going on. And it's okay to ask for help, and we do encourage you to ask for help. Counseling can be helpful, or reaching out to other caregivers through the foundations can be helpful to look for things. Sometimes people can share with each other what things they found helpful for them. Asking friends and family, can you come in and help look after my spouse for an hour or two and allow you time to go out and have some personal time, is very important. So if those resources are available, to ask for them. And then I also wanted to talk about palliative care needs. So this is important to talk about as well, and it's a difficult conversation. But it's important to talk about, and this can be a conversation that happens early on, or it may happen later on. But sometimes it happens, as a kind of a last minute, as like an urgent discussion, where ideally it's maybe better had earlier on in the disease course when things are not urgent. But usually these conversations come up when there's a periods of distress, where patients are not coping at home, or family is not coping at home. There's lots of different services available to try and help with care assistance. So there's respite care, in-home health assistance, hospice, and counseling. In all of these conditions, the most common reasons that lead to death is immobility. So all the complications of being bed-bound or wheelchair-bound, or problems with swallowing, choking on saliva, choking on liquids, choking on solids. And they go down the wrong way into the lungs, cause a pneumonia, which leads to sepsis, and then passing away. And they're the most common causes. The thing is, during being followed by your neurologist, they will ask always about falls, and they will ask about swallowing problems, because these are the two issues that get people in trouble. And if we can prevent falls and injuries from falls, which leads to immobility, or we can prevent swallowing difficulties by modifying the diet, maybe thickening liquids or changing the diet, may hold off some of these complications. And then it's also important to think about advanced cares. So what would you like to happen a year from now, or as the disease progresses, and to think about having those conversations early on. I know it's very difficult, but if they're had early on, it's actually a great opportunity, because this is a time early in the disease course where patients are usually free of dementia and they can express themselves very well. And it's helpful to think about listing wishes for your goals of care, for what future treatments you would like or would not like. Artificial feeding or ICU care or resuscitation, where you would like your care to be given. Do you want to be cared for at home? Do you want to be cared for in a nursing home? And where would you like your place of death? In a hospital versus at home? And if these wishes are not made known or articulated, then sometimes when it comes to those particular events in the disease course, family is trying to make the decision on behalf of patients, or the medical staff are making those decisions on behalf of patients, but maybe that's not in line with what patients want. So trying to have these conversations early on with your family and expressing your wishes can be very helpful. So later on in the disease course, everything is directed at your particular wishes and desires. And as part of that, making a will and funeral plans is very difficult, but can actually provide a lot of help for a family, rather than perhaps these things never being discussed. So I bring these up because sometimes these issues are not discussed in clinic, or the clinical visit is taken up with urgencies like low blood pressure or falling or problems with swallowing, and we don't get time then to discuss these particular issues. Unfortunately, there's no specific treatments available directed specifically at MSA or PSP or CBD. There's no specific medicines that will treat the underlying disease, but there are a lot of clinical trials going on looking at therapies to try and see could it slow down the progression. So I've listed here clinicaltrials.gov, which is a government website that lists all of the trials that are currently going on around the United States and overseas relating to these conditions. So if you go to this website and put in the name of the disease, up will pop all the current trials that are ongoing. So for example, I did this search on June 14th. This was for PSP. And I put in what are the current trials currently recruiting or not yet recruiting. They haven't yet started for PSP. And there's 20 studies going on, one of which is going on here at Mayo. And so this information is always updated and current. So you can look through and see where are trials going on, what are they doing? Are they doing medication trials? Are they just doing imaging studies to try and understand the disease better? So if you're interested in participating, you click on the particular trial and there's usually there's a contact name and number to find out more information. Similarly for CBD, there was 12 studies currently ongoing in the United States. They're ongoing or not yet, or about to recruit. And for MSA, there's 21 studies. So that link's available in your handout. And then the resources can be very helpful. So these are the foundations that have the most accurate medical information. So that's for the different disorders. There's CurePSP in the USA. There's a European PSP Association, the MSA Coalition, and National Ataxia Foundation, National Parkinson's Foundation. Okay, so I'll be happy to take any questions. Yes.
You know, I found that in our area, my wife wanted to go to, she wanted to go to certain groups, like I wanted to go to caregiver groups, but there aren't any for the patient out there. There's like maybe one, and there's dozens of caregiver ones out there, but there's none for the patient who really wants to discuss, what's going on with her with another patient that may be having the same symptom.
Yeah.
So and there's really not a lot out there. So.
Yeah. So with some of the foundations, they do have patient support groups in each city, but it kind of depends where you are geographically. So if you're in a big city, there's going to be a lot more patients with the condition. But I do know of patients that have, because there was none in their area, they set up their own patient support group. So they reached out to the foundation, the appropriate foundation. They said, I'd like to set up a support group in my area, and can you help me do that? Yeah.
Facebook also has a very active organization, this multi-system atrophy, for example.
That's right. They have the MSA Coalition. Yeah. They are very active on Facebook.
Very active on Facebook.
Yeah, they organize walks and other fundraisers for MSA. Yes?
Cases of using vibration plates or machines for muscle stiffness?
I'm not specifically familiar with those, but that's something that our physical medicine lecturer might be able to answer for you.
Thank you.
I just would like to reiterate what you said about the advanced directives. My mom passed away in October from PSP, MSA. My aunt and I are here just to learn more and see what I could do more for this. But knowing what she wanted made the process so much easier for my aunt and I. I was in Germany while she was here caring for her, and I knew what my mom wanted, my aunt knew, and it simplified. We knew going into it what we all wanted for her treatment. Mm-hmm. And when we got hospice, it made her feel so comforted to know that all of her wishes were really granted. She had a beautiful death, and a lot of that was because we had that conversation, which is incredibly hard. Nobody wants to talk about it. But man, at the end, it made it beautiful, I think, for both of us. One thing my aunt said is she taught me how to live and she taught me how to die, because she really, she knew what she wanted to do.
Thank you for sharing that. It's very helpful. Thank you.
I also wanted to address the advanced directives, but it's important. Our primary doctor gave us
there you are. Okay.
the physician order for life-sustaining treatment, the POST form, and we filled it out right away while she could still speak and give her opinion on, what kind of life-sustaining treatments she wanted. And now we have it plastered on our refrigerator. We bring it with us when we travel so that if we have to call 911, we can say, this is a signed physician order, this says what she wants, and they don't have any question.
Thank you. I think this. Okay.
This is in regards to the Botox you talked about.
Yes.
Our neurologist suggested for the eyelids. My concern is if the Botox keeps the eyelids open, what about the dryness and the sun brightness for the eyes?
Yeah, so that's a very good question. That might happen if the eyelids are over weakened, so then they have trouble closing. But generally speaking, if someone, at least at our center where we're injecting with Botox, we start off using a very small dose and seeing how patients respond to that and seeing if that's helpful. So if it just weakens the eyes enough slightly so they're not spasming shut, but they can still close their eyes, and then we gradually bump up the dose as necessary. Yeah.
We're in year 7. Dr. Bauer diagnosed my husband with PSP, but now I'm seeing the foreign arm and the foreign leg.
Mm-hmm.
So is it common that he still could have PSP, but they have these crossover of symptoms, or?
Yeah, that's a good question. There is a lot of crossover between the conditions. Alien limb tends to be fairly specific for corticobasal syndrome, but it has been seen in PSP. So there really is a lot of overlap between PSP and corticobasal syndrome. So it doesn't necessarily mean the diagnosis would have changed.
Thanks.
Okay, and there's a lady here who's waiting.
Yes, how do you calculate the longevity of the disease, like specifically with MSA, you said 1 to 18 years?
Yeah, so I didn't do that.
What's the signpost for like, oh, it started here with these symptoms, and therefore it's like 5 years?
Yeah.
Or
So the 1 to 18 years actually just developed the rate of progression. So I think that's come about, for example, personally can recall a patient who looked exactly like Parkinson's disease without any other features of MSA for well over 10 years. And then after that period, they developed all these typical features of MSA, and the diagnosis was changed at that point. Mm-hmm. So that's what they refer to as the progression. How is the disease progressing? So it's very variable in the time range. Mm-hmm. In terms of the survival, is that what you're asking? Sir?
yeah, and just how you can say, oh, I've had MSA for 3 years.
Oh,
or
I
I've
see.
had it
Yeah.
for
So we
6.
tend to time it from what was the first symptom. So when patients come in, they may say, "Oh, I've had problems with my walking," but we'll go through a whole list of questions for these conditions in general, and trying to really pinpoint what was probably the first symptom. Was it the bladder issues that started 2 years ago? So where did the disease start? And we time it from there.
And so are some of the manifestations of the disease more significant than others in terms of calculating that?
That's a good question. Some of them do have more prognostic value in terms of how they progress over time, or are they more like, is it linked to a shorter disease span? And there's specific papers out there on those, but there's something that would come up on an individual basis in the clinic.
Okay, thank you.
Okay. Sorry, I'm getting cut off. Okay. All right.
One more question.
We have one more question. This lady in the front has had her hand raised in the blue. Yeah.
Oh, I'm sorry. I'm sorry. I just wanted to know, I have such a problem with daytime sleepiness. I mean, I sit and my husband keeps bumping me because I fall asleep. And my friends get very upset with me, if I go to a movie with them or something, and I fall asleep, and I go, oh, I'm not doing it on purpose. I don't know how to stop it. I don't know what to do for it.
Yeah.
If there's... I know you mentioned some medications.
Well, there are medications, but actually we usually go back. So it would be helpful to speak with your doctor and to explore your sleep pattern. So what time you go to bed? Are you sleeping through the night? How often are you getting up overnight? Do you snore? Do you have abnormal movements? If you have a bed partner, that can give some history about what does your sleeping pattern look like. And they take all that information, because if there's some underlying sleep problem like sleep apnea or some other sleep problem, that can make you sleepy during the day.
Yeah.
And so we try and address what's the underlying reason. Some people are just sleepy, and there's no actual sleeping problem. They're just extra sleepy during the day. And in that situation, there is medication that could be prescribed to make people feel more alert during the day. But that, again, so I would recommend to speak with your doctor.
Thank you.
All right, thank you, everybody.
Dr. Hassan, thank you so much. Thank you.